Good morning, everyone. You are welcome to this meeting, and we are happy that we're able to host this webinar on the topic that we have chosen at this time. The title of our presentation is looking at the issue of non-compliance of to COVID protocol. This is a very important issue, especially at this time that the whole world is expecting and also battling in some places with the third wave of the pandemic. So in order to ensure that our society is safe, it is important to address the preventive measures and to understand why people do or do not adhere to the protocol. First, I want to appreciate the Center of Excellence in Migration and Global Studies of the Open University for allowing this webinar to host on their platform. This is the second one in the series of webinar that we have lined up for as activities of the Social Science Working Group of the NCDC. So this morning we'll be engaging our audience three topics. The first is non-compliance to COVID-19 protocol, where we have Professor Asusu, Professor Okoye, and Professor Obono. The second topic to be discussed is reasons for non-compliance to COVID-19 protocol. Professor Jegede, Professor Shaibu, and Dr. Kelly. And the third topic is consequences of non-compliance to COVID-19 protocol by Dr. Oshu and Dr. Amino. But let me just say that Dr. Oshu has mentioned I think he sent a message that she will not be available at this meeting this morning because she'll be attending another important meeting at the same hour. So probably Dr. Amino will want to speak on the consequences, while the discussions will also support that aspect of the discussion. This webinar will be from 1 hour, maybe 30 minutes, and within that period, we have time to for contributions from the audience, and also people want to ask questions, and then responses by the presenter. So we want to start now with the first topic. Professor Asusu, Professor Bono, want to go first because it's we want to leave immediately for the airport in his location, so that able to engage him. So may I call on Professor Obono to start with his presentation for 15 minutes. Thank you. Professor Obono.
I thank you for your kindness, and Professor Jagade for your excellent sharing, and Professor Tijani for again availing us the use of your center. Thank you so very much. And Dr. Aneto for co-hosting. The issues with non-compliance clearly remain in part the same as questions we have addressed in this thematic working group about a year ago and during the lockdown, but more recently with respect to compliance as it deals with vaccination. And why is it that the level prevalence of vaccination in Nigeria remains suboptimal? Why is the skepticism still so deep? And how do we overcome these kinds of issues? So with regard to the more basic issues, the use of nose masks, hand washing, hand sanitization, and physical distancing, all those will be a quick rehash in about a minute or so of questions we had identified before. We live in Nigeria in an occupied area that is far smaller than the arable land around it. And the consequence this has for human occupation is high population density. Density in the sense that people are choked within limited spaces. And even in the farming south, you find that farming takes place in what anthropologists describe as nucleated settlements, which means that the people live in one part of their total land and then farm out. They trek upwards of 10 kilometers in order to access the farms. And perhaps the host can mute all of us. You'll realize that one or two participants have their mics on and there's background noise. As an aside, host, can you mute us? Thank you very, very much. Appreciate it. So there is this tendency we have for living not in isolation of one another. That isolationism, of course, where you see peri-urban and suburban settlements, where the rich retirees tend to take themselves away from the mass of the society because they appreciate privacy. Within that kind of context, you already have embedded in society a natural form of physical distancing. But when you move beyond that, to the generality of the populace, that natural distancing does not occur. In fact, people engage in activities that routinely bring them together in very close contact, whether this be the huggings at weddings or the, nature of interment at funeral services, naming ceremonies where people must obligatorily carry the baby, and all sorts of culturally induced practices. And up to this point, we haven't really provided any firm messaging to how you can retain the value of these cultural practices while mitigating the risk factors implied in them. So I think at that level, there is an intellectual basis to the non-compliance to issues like physical proximity. In any case, what physical proximity was able to achieve has not been replaced by any form of distancing in the delivery of services. Okay, so the services have to be delivered in the market. For instance, people have to go to Aleshin Loye, they have to go to Ogba Market in that physical proximity. Now, if people don't go into such places, how have we engineered a way of bringing those services to them in, distantiated context? We haven't done that. So these sorts of systemic issues have to be taken into account. We've also seen the issue of the use of hand sanitizers, which the poor can't afford routinely. Okay, if there was a mass production of these and it was supplied at a highly subsidized rate by philanthropists or the state or so, that's a different thing. But currently, anybody using hand sanitizer either obtained it tokenistically from a conference they attended or so, or they had to buy it. And you and I probably can afford it. But over 75% of the Nigerian population, remember, this is the poverty capital of the world that you are dealing with. The priority for such persons who live in very desperate circumstances, I mean, sad to say, it's not hand sanitizer, it's how to feed their children, keep them in school, keep that roof paid for over their heads, have drinking water, clothes, the basic, basic needs that have been identified, and everybody is familiar with them under the hierarchy of needs by Abraham Maslow. We haven't gotten that right. We talk about the use of water. Again, that has gender implications. Who's going to fetch the additional water in addition to the burden of chores that people within that sex category and within the certain age band already suffer from? So it increases, the burden of labor, unpaid labor for some members of society. We haven't found a way of taking mobile tanker systems through the neighborhoods to supply water, and we are asking people to comply. It's easy to comply if you are a guest in Professor Suzu's house. You can wash your hands and your clothes as many times as you like. It doesn't cost anything. The water is always there. Similarly with Tijani in particular and Jegede. When you use those kind of people as standards for policy formulation, then it means that you are not really focusing on the people who require that policy more than anybody else. Now, the conditions in which they live, they don't take things like water for granted. They have to buy it, they have to fetch it. And again, this has implications for the, economics and all that. So I've just tried to look, not that we have this kind of hostile people who just don't like to do what people ask them to do. There are systemic dimensions. It's not always irresponsibility. Sometimes it's sheer inability. We need to empathetically look at these kinds of issues in order to guide the obligations of those who have the responsibility to provide certain infrastructure and an enabling environment for the behavior change that we seek to actually take place. That is that dimension. Then when it comes to vaccination now, you have a situation where there is discordance in the messaging out there. Every time, a lot of that is driven by the hysteria of social media and the conspiracy theories that are out there. Very few people will be able to glean the truth from the concoctions that certain individuals just sit down, and I don't know why people actually derive any joy in that. Some of them are coming back and confessing that they deliberately told lies and all of that, but the harm has been done. They have gone online and sent out ruinous information, false kinds of rumors about magnetization. If you put magnets where they give you the vaccine, if you took a bulb, it will light and all those other. And for people who do not understand the mechanics of virology, they begin to think, what is this that they're implanting in me and all of that. So here, there's a place for very strong, consistent, focused communication. We need to find a way, maybe not necessarily through the same social media, because social media will percolate, but bad news travels fast. We may need indigenous and in that context that people who are more vulnerable to such lies, will receive them, be able to ask questions, and then have their issues clarified. We just have to work within the existing health system. We have all these health personnel who work at the primary level. We need to depend on them to get this message across. But right now, the of the skepticism is being driven. So sometimes it is not just about non-compliance, it is people trying to act again in this sense responsibly until they are able to make up their minds. That's really where this thing is. Non-compliance seems to connote that people know what is expected of them, but they don't want to do it. either because they think there are political overtones or baritones involved in the matter, or there's an ethnic tincture, there's an attempt at racial genocide, a re-Rwandization of the process, and because of that, they are not going to get involved. Sometimes it is not as extreme as that. It may just be that there's discordance in messaging out there, and people are waiting to have concordance first, to have something definitive, to have a minister coming out almost daily, speaking on the same note that this is what these vaccines are all about. To even have traditional rulers, paramount rulers, religious leaders, political leaders coming out and setting aside their political religious differences and singing from the same hymn book on the same note. If we can walk towards that direction, while the health experts are doing what they are well known for, if we can move in that kind of direction, I have an expectation that this non-compliance with regard to vaccination and other issues that have been broached earlier in this brief presentation, the compliance level will go up, the non-compliance will come down. Thank you for your attention.
Thank you very much, Professor Bono. Professor Azuzu.
Okay. Yes, sir.
Yes, your turn.
Yes. Good morning, everybody. Our batch, this first batch, I suppose we are supposed to be talking about the phenomenon of non-compliance. And the second team are to talk about the reasons. And the third team are talk about how we repair it.
Yes.
But talking on the phenomenon of non-compliance, I think it's important for everybody to know that non-compliance is not a new thing. It has happened with every public health issue for disease control. I think the most notorious that we know about is about whooping cough vaccination. At the time it was first brought out, many people didn't want to take it until epidemics of it began to go wider. And then the health systems realized that they must go out and give education massively and showing example of what happens if you don't get the vaccine. And then people took it. And we had discussed this before, some of the issues. And I thought that perhaps after this internal discussion, we should also have a wider webinar so many people will be part of it and know what to do. Now, generally, for non-compliance, there are three categories of people, or reasons why people will not comply. They didn't get the information. Information didn't reach them duly. Two, there are conflicts in the information. And finally, there is wrong information that people have been given and concocted the confusions. And the three of them are categories that need to be dealt with separately. As a community physician, I have kept saying it, who have gone around the world a little bit, about best practices. We are community people as Nigerians, anywhere. And it's amazing that Nigeria is one place where community health care is not being done. We misunderstand public health. Public health should not be a top-bottom thing. By itself, that's the way it runs. But since 1978, Alma Ata had told everybody that we must change that paradigm. Public health can stay with the way it is, but when we get to the community, we must dovetail it so that community takes charge, has the knowledge, is involved with the planning, implementation, evaluation, and replanning of what they want to do. Public health in Nigeria has remained vertical. And if it remains vertical, it will not work. That's what Alma Ata has told us. The way to do primary health care is to have people, public health workers, who are community health workers. So they live in the community. They have the legal system. They have the authority. The people know where they live. They know where they work. And they can't afford to tell them lies. Because if they tell them lies and they want to revenge, they can go to his house and kill him there. So he will tell them the truth. In 1859, when William Rathbone, politician in Liverpool, his wife had a chronic illness, he knew he can't afford to keep her in hospital on admission. So he kept her in the house and went and hired a nurse who will come to look after her at whatever periodic intervals he thinks is reasonable, maybe one in every 2 days or 3. When he found how useful this is, he pleaded with the health authority in Liverpool that this should be generalized. And so they started employing people they call community nurses. And he said they should not assign more than a 2,000 population. At that time, Liverpool wasn't this urban. There's rural parts of it. So 2,000. So he will know them. He will know where they live, where they sleep, know the whole family. And she will know those who are chronically ill, visit them at home. And while she's doing that, she can interfere with any other thing happening in the village. She will act and be seen to be the community's mother in relation to their health, happiness, and well-being. So community health practice, primary health care, without a community nurse midwife, makes public health to remain vertical. Strange people are the ones talking to you in the radio or come with the microphone, loudspeaker in your village. You leave them. If you don't have anything to do, you're watching them. But if you have something, you go. Don't ignore them. And when they finish, they say they came to do their own, collect their own money and go. You don't give attention to it. There is no reason in Nigeria that we cannot have community nurse midwives statutorily appointed. The primary health care agency that is driving our primary health care says the unit of our primary care will be the political ward. Fantastic. Nigeria has 9,565 political wards. So if we cannot find one nurse midwife, public health trained, for all of them, we will find at least for 1 or 2 examples. And we have trained junior ones, senior ones. As of 2012, when we had the first national conference on human resources for health in Nigeria, Nigeria had trained out 47-point-something thousand CHUs. So if we are to assign CHUs to political wards, each political ward will get probably 5. That's in excess. But where are the CHUs? Most of them are not employed. They are looking to be employed as nurses, and they are not nurses. Or they open their own patent medicine shop and they are selling. We have our organization of our health system is something else. Can we do this so that these people are giving information to their people? When other vertical public health authorities come and say the same thing, they are the same thing. If they are in doubt, they can go and ask this person. And that each local government should have a medical officer of health who is a full-blooded professional specialized in this field. He can challenge the state government if they are not doing the correct thing. He can challenge national government because he's a specialist in his own right. You know, gentlemen, our colonial public health laws require that every local government in Nigeria must have a medical officer of health. But when it is not possible to appoint one as such, the doctor in charge of the general hospital that looks after that local government must also act as the medical officer of health. And what they did was, of course, to employ environmental health officers and share this task with them. So even in the colonial time, we're able to do this. Our law has not provided for these essential community health workers. The medical officer of health is a community physician, a statutory public health nurse midwife, who is a statutory community nurse for each political ward in Nigeria. And where you can't find them, send a chew. But she will be, I mean, at least the nursing sister in charge of primary health care in the local government will know these paradigms. And with her and the professional nurses who look after at least one or two political wards, they will give coverage to the other people. And if there's a medical officer of health, they can always call it. If we fail to organize a health system like this, so the people already know who they should query if they hear any information and get correcting. And these informations are agreeing, both the one they are saying and the one the people who come from the state or from the federal government or from international agency are saying the same thing. We will continue to have these categories of conditions that make people, I mean, not talking about specific, people didn't get the information. They got the information, but they are conflicting. There are no people, trusted people living with them in the community who are professionals, who they will verify anything anybody tells them. Or they have moral or ethical reasons for objecting, or they are following fabricated stories, you know? So those are the issues. Obono had mentioned a few other things, but in terms of category and types, I think these are the things we need to know while we discuss the specific causes and what to do. And I think it is in that area of discussion that will really meet the meat of what we are doing. But please, I think that when we do this very well, we should hope to give a national or even wider webinar, so that more people are educated on what needs to be done for our country. Thank you very much.
Thank you, sir, for that video presentation. Professor Okoye, are you ready?
Yes, I'm ready. So we are still in good morning, right?
Yes, good morning.
Good morning, everybody. Thank you for the opportunity to make a contribution. And strictly going to probably just apply myself to non-compliance, just the issue of non-compliance. Is it the non-compliance syndrome to COVID-19 infection and protection practices? What is happening around us is almost like it's a big joke. Nobody seems anymore to be taking cognizance that these measures are supposed to be adhered to. The usual sight of seeing buckets of water with taps available at different entrances of public places are fast disappearing. Those that are still existing do not even have water in the buckets, and barely any hand sanitizer. So you find that the people who are still paying attention, even in the airports, a lot of the airports, when you come in, you barely see people at the entrance, trying to take your temperature, engaging you with taking up the hand sanitizer. sanitizing your luggage, or even, and then everybody is meant to wear a mask, including the airport officer that is meting out this oversight of people who are supposed to go in with their mask on. He himself has his mask on his neck. He has his mask on his neck, and he's completely oblivious to the fact that he might as well not have a mask on. So he's standing there and he's passing people who have masks. So it's just a matter of, do you have in possession with you a mask? So you have different categories of mask wearing, from using it as a necklace to wearing it just to cover the mouth. And then the one that is very, very regular is just covering the mouth and the nose is open. Most of the time, even when, at functions, people have written clearly on their cards, their invitations, that COVID-19 protocols will be strictly, observed. It's a big joke. You get there, even the person who has sent this invitation to you is not wearing a mask. Neither has he made any effort to make sure that there is physical distancing. A lot of people even, a lot of people confuse, or is it that they have absolutely no knowledge of the difference between social distancing and physical distancing. So you keep hearing people talking about social distancing when they actually mean physical distancing. That physical distancing is completely, mostly unavailable, mostly never adhered to. Even when people are taking pictures these days, in the past, you see people either they are masked and they have a physical distancing, or they are masked and they are not observing physical distancing. And I tell you that it cuts across board to places where you expect that people should be complying with these measures. From the universities, university communities, to churches, to markets, to fellowships, to outreaches, to hospitals. It's a hospital. I work in a hospital. It's a hospital that completely astounds me. From doctors to ordinary staff that are maybe the porters, the cleaners, and then the patients. So the doctor is in his clinic. Perhaps he's the one that would decide to mask. The nurse also may have her mask on her neck. And then if you go out into the reception area, you find hordes of patients seated close to one another, no physical distancing, and just a few of them scattered wearing masks. In fact, the other day I came with some visitors from the UK, and I went into a teaching hospital, and I was so tempted to snap them for this lecture, to be able to just show what I'm talking about. And the aspect of, my husband and I went to a funeral, and we came in there fully masked, and they were making fun of us. So there's even stigmatization. People are afraid. If you go to the market, you're wearing masks. They will tell you, do you want a raincoat as well? They'll make fun of you. So people do not believe. In fact, the threats they feel, that is at home with our people now is the threats of unknown gunmen and kidnappers. That is the threat that they think is in existence. They don't think that this threat is, there. And we're talking about vaccine hesitancy. Vaccine hesitancy prevailed across board, not only to the educated, the uneducated, in the rural communities, even in the urban communities, cutting across, even to the fact that medical doctors were guilty of vaccine hesitancy. I'm sure that if there is a survey that is made, you'll find that a huge number of healthcare providers did not bother to take the vaccine. Unbelievable. And they will tell you boldly, they are all believing the conspiracy theory. So since it's not actually my place, from the topic that I was given to talk about the reasons and the outcome of not adhering, I would like to announce to us that this morning I woke up and I saw, an announcement that the dreaded Delta variant is here with us, that 3 people have been found to have it. And there is also the new variants in the UK. So what are we talking about? Nobody is taking this issue of masking, of physical distancing, even social distancing, even the conferences now, medical conferences, and all being pushed to be physical. I don't know what, so we are no longer in the new normal of trying to keep away. We are back to the old normal as a routine. So nobody is paying any attention. So there is definitely declining adherence, even in the schools, declining adherence, and a lot of stubbornness associated with it. Like, I mean, if you tell somebody when you want to physical distance in a function, and you tell the person this seat is not supposed to be occupied, it's occupied, he starts fighting you. So that is how much of non-compliance we have. Thank you very much.
Thank you very much, Professor Okoye. I'm stepping in because Professor Jegede team will be presenting the reasons for non-compliance to COVID-19 protocol. But before Professor Jegede speak, I'm not too sure whether Professor Shaibu and Dr. Kelly are here with us. I've checked the participants. I can't find them. But if they are here, they can kindly unmute and then speak after Professor Jegede. But just to quickly say that, in fact, Dr. Gloria Aneto and myself, I believe, we shared the same, knowledge of this horrible and what I would refer to as a neo-sittingly sickening trend, and I call it, quote unquote, the Kogi madness that has now pervaded and continue to pervade Nigeria and perhaps outside Nigeria. What do I mean? Sometimes ago, I believe about 3-4 months ago, there was a women football event that I was invited right there in Abuja. And I got there, they told me 10, I was there 9:30, and they were still organizing. But what was shocking is the fact that I was an alien in the midst of these people that and I'm saying this with all sense of responsibility, and it's so annoying. These people, they approached me and say, I was introduced by, this is Professor so, he's one of our guests. And they started asking me, why am I wearing a face or nose mask or whatever? I said, don't you know there's this thing around? They said, no, it's fake. They, prof, you too, they. I started looking at them. So I asked the Ajia, I say, because myself and Ajia, the organizer, happens to be one of the only, maybe 3 of us in that huge stadium wearing. And I said, who are these people? She said, prof, don't mind them, they are Kogi. I said, Kogi people. I said, the chairman is Kogi State Governor. I said, really? And I checked my time, it was 10 o'clock. And I said, I see. So I'm going to sit with these people. I said, Ajia, I'm out of here. I am out of here. I happen to be a victim. I've contracted it. I survived it. So they can't tell me there's no COVID. So this madness must stop. Whether you call the Oba or the Bale or the Eze or the pastor it's just that some of us, we need to re-engineer our psyche to really understand. Even if you have Lai Mohammed coming out every day, they will refer to him as Liar Mohammed. That is not a reality. Because if you have a young governor, somebody as young as a governor of Kogi, just, being one of the most dangerous abinger of this fake news that COVID is not real. I don't know what we can do. The future of this most populated country in Africa is endangered. So I will rest my my thought, and I have no apology to anybody, including the governor. I have no apology. I think they need to reorientate. They need to check the psyche of some of them. There's a huge mental disorder going on. It's madness. So please, Professor Jegede, except if Dr. Aneto wants to say something before the panelists, because she talked about the variants. So thank you.
Thank you, sir.
And by the way, I'm sorry to say this. By the way, this section is not about theories, concept, contextualize. We are talking about real evidence, ethnographic evidence of what is going on. It is not we have science, go to the laboratory. This thing is happening and it is real, so we will interject at another point. Please. Okay. Professor Jegede.
Thank you very much for that presentation. And to discuss the reasons for non-compliance. I mean, the view is not quite different from what all of us have observed and known going on in the society. This issue is becoming embarrassing, especially when you go to places and you discover that you are the only one observing, and then you become a you are the only one or odd one out among the several individuals in those places. It has happened to me several times, but one thing I have tried to do is to make sure that I have responsibility to myself, because the responsibility for my own well-being is in my own hand. And so regardless of what other people will be doing, first of all, I have to first perform my duty to myself, so that I'll be able to help others. So I've grouped the reasons into 3 categories. As a sociologist, I look at it from the individual level, community level, and governance level. From the individual level, there's this peer influence. People want to, live the way others around them, their friends, their people who are close to them, they imitate. You see people, when they go to places, they wear it, but when they get there, they see their friends, they remove it. So that is one challenge. And sometimes it may be difficult to change this attitude, because it continues to increase by the number of individuals that come into that company. Secondly, is perception of the disease. Some people still believe that it's still it's not true. It's not. They are just trying to colonize Africa. They want to. They are using it for political reasons and so on and so forth. So the way people perceive it is, and then some people also feel that it's by being African, it won't have much impact on them. So we have had all sorts of stories before, and so perception is very strong issue, and the attitude towards the disease, even when they know that disease is real. How do people relate to it? And I take my example when it's both perception and attitude now that this example we fit into. The case of the late president of Tanzania. I used to watch the man on video several times, especially when he goes for the church services where he drumming and making people to feel as if nothing has happened, that it's not real. But lo and behold, the rest is now story. So there's also the gender factor. Some issues relating to women activity, ways of life and things like that, and also men, because we differ in several ways, and some of these things also account for why people may comply, may not comply. Professor Bono mentioned something earlier in terms of, say, for instance, hand washing, the issue of hand washing. Who's supposed to provide the water, especially in the low socioeconomic environment, where water issue is traditionally solved, not, no pipe-borne water. People have to go and look for their own water elsewhere. Who gets the water? And where the water is fetched, the issue of distribution of the water also is an issue. Who gets what at the household level and community level? It's very, very important. Also, the use of face mask between male and female is also an issue, because the activities carried out by men and women differently allows for some comfort of the use of this face mask. But for instance, in the community level, where you have this traditional housewives group that normally relate to family members and try to celebrate, participate in celebration, do all sorts of things at the family level. Sometimes, some of these things are taken for granted, and people just wish it away as if it's not important. Age is also important. Age is important because
and then Professor Shaibu can take over when you start.
Okay, you have a situation whereby children are not. People don't bother to even wear for children. You go to places, you see children running up and down, and so they may not be really affected, but they can be carrier. At the community level, the environment where you find yourself is important. Rural-urban divide is an issue. In the urban area, you can find people wearing it. In the rural area, you may roam the whole community. You may not find a single person using. I experienced it when I went home recently. I found out that I was the only one, and everybody was looking at me as if I was doing something wrongly. The economic activity we engage in. For instance, load carriers at the marketplace, wearing face mask may be a challenge for them to carry out their activity because of the nature of work they are doing. And information is very important. I think Professor Bono also mentioned issue of this information, the rumor. That around the COVID pandemic. Has done a lot of damage. In fact, recently, people showing the different kinds of information about the vaccine, using a bulb to show that when you put it at the point of your vaccine that I mean it spark electricity. So these are all sorts of information that I mean goes around. At the governance level, leadership is very important, and I mean I'm happy that Professor Tijani has cited a very good example. And it also happens at religious level. Whatever the religious leader says, it becomes the order of of the day for members. And even our health workers, some of our health workers provide information they provide. People will say, oh, so nurse told them that this is what is necessary, this is what is not necessary. So the information provided at the individual level where we provide the leadership becomes so important. And that is why you find that even in some places, in some congregation now, they don't even see the issue of physical distancing is no more observed. Finally, is enforcement. The enforcement of public order is very weak in our society, and something must be done about this for us to be able to achieve the purpose of the whole activity package for prevention. Thank you.
Thank you very much, Prof. We will take Dr. Aminu. If the person that's signing as Francis Aminu is the same Dr. Aminu, can you unmute? Because Professor Shaibu just, I think he left, maybe he's having some challenges. We can just go to the third group, since I believe Dr. Chu, Dr. Francis Aminu, kindly, we'll give you 5 minutes because Ochu is not joining.
Thank you so much, Prof. Good afternoon to you all and my distinguished professors. I thank you for this opportunity to really learn more from you, let me put it that way, and then make my just modest contribution. And whatever I'm going to say this afternoon doesn't represent the opinion of Dr. Ochu, because we didn't really have time to discuss and cross notes. So I'm just saying it as the little I know about it. And having listened to others, my distinguished professors, I've really seen a lot of things that I would have loved to say, but I will just summarize by saying that, yes, nearly a year after the emergence, government and non-governmental organizations, they have accepted life during the pandemic as what we now call new normal. But after those months of restrictions, what we even call new normal now, which I've learned from what we have said, is really appalling. Our new normal is even worse than our normal way of life when it comes to kind of disease prevention and then control in the process. Although in Nigeria currently there are no rising COVID-19 infections, we're just more or less flattening the curve, and we're maintaining that. But just like what Professor Okoye mentioned, we've just heard this morning that there are cases of Delta variant, which is really being recognized by the WHO as a variant of concern, given its increased transmissibility. And then this will really be very, we have to be careful because it has been detected in over 90 countries, and is expected to spread to more countries. And now we've opened our borders, we're crossing borders, and people are coming in, we are going out, and we are coming back. Just like an example, over the weekends, a very close family of mine, I've not heard from them. I was really surprised to find out that the father, the son, the two of them are in an isolation center, and I didn't know about that, because, and these are people who will ordinarily not believe what we've been saying, what the science is saying at the end of the day. So with all this, it's like, yes, everywhere, public spaces that are formerly out of bounds to people without face masks have now become accessible to everyone. And everyone is mingling like as a normal life as usual. And Nigerians have thrown caution to the wind, as been professed this morning. I mean, this day, with the turnout of people on the streets, in the plazas and banking halls, with no regard or respect for NCDC. However, and so far, non-compliance has resulted in no sanctions. So nobody is sanctioned for not complying, but we should be rest assured that there are so many consequences. And I have just few of them that are key that I like to raise for us to look at. One of them is that there definitely may be a kind of, if we continue in this light, there may further development of worsening, which the development may worsen the spread of the infection across the country, especially with the way we are going. There might be an exponential rise in the reported cases of COVID-19, as no one can actually quantify the level of transmission that is going on. Many of the states are no longer testing. We found out that. And then, so you don't actually know what that is going to be. So this could lead to more hospitalization with serious pressure on the hospital resources. And then we're back to our usual way of rushing and pushing everything together. And then if the disease could rise again, and perhaps exponentially, as I've said, then there may be a repeat of the lockdown if care is not taken, especially in a place like Lagos, that is like always the epicenter and then the point of entry to Nigeria. So this will have both social and economic impact on the citizenry. So we're like the convener said, we're already impoverished, and then we'll have more of lockdown really pushing us to more of poverty. And like I said again too, this is going to have a serious health consequences for oneself. So it's not just going to be for our loved ones, but for oneself as we continue to have our social gatherings and economic activities. Any actions we take that increase our risk for contracting COVID-19 will make us more likely to carry the disease home with us. We carry the disease to our offices. We carry the disease to our various gatherings. And once we be the spreader of the disease, and then we need to really think about our loved ones in our working places that we hope to visit. Especially, we are expecting the religious celebrations coming up. That of Ileya Festival is coming up soon. So people who have left their guide will continue with that. So they need to really think seriously of these key consequences if they don't abide or adhere to those COVID-19 protocols that were given. Thank you so much for giving me this opportunity.
Thank you very much, Dr. Aminu. I think we can have a quick intervention by Dr. Aneto.
Yeah.
And the floor is open.
Yeah.
Dr. Aneto.
Thank you so much, sir. I was actually out for some time. Network threw me out. I just want to add my voice to that of others to, first of all, thank everybody for these beautiful contributions here and there, and this topic so timely, and I pray God will help us in our country to really have a change. I want to say, I don't want to agree that our cases are not increasing. The last speaker, I think, is of the view that we are in control. We are doing very well. Yes, we were doing well, but from what I saw this week, I became worried. In the last 4 days, we have been having increase in the cases steadily, exponential increase from 50-something to 60-something to 90-something. Now it's 110 or thereabouts. I saw this morning over 100. And if it goes like that, if tomorrow it increases beyond that 110, then we know that something is happening. So we must not rest on our oars. And then I really want to agree that in this country, I think it is only force we need to hear word. Nigerians don't hear word. I want to put it that way. We are all very guilty. We need force. It's only when there is force that there will be some order. And I also want to speak, agree so much with what Professor Asuzu said concerning the grassroots involvement. That is just it. That is really public health. He was saying it, and I was worried that this is a public health we are all expected to practice right from the grassroots. And so what is government doing with resources to help this to happen? Because to say we want to really be at the grassroots, yeah, the nurse may be living in the community or whatever, but sometimes we also need some push from the government to help this to happen. So is our government really giving it its best for now, or we have all relaxed? If you go to the airport right now, the seats that they used to put red in between one, don't sit. All those things are gone. We all sit together in the airport, especially in Nnamdi Azikiwe, where I often enter, and Lagos. We all sit together. Nobody is doing anything again. It's like Nigerians have discharged themselves fully and say, yes, we are free from COVID. We have given ourselves the license, the ticket to say we are free. Nigeria is exempted from COVID. I think that's what we are seeing right now. And somebody was trying to convince me, you can't believe it, this week I gave a ride to somebody and was trying to convince me that, look, there's no COVID. Are you also believing? I said, do you know who you are talking to? Perhaps I have been practicing nursing before you were born. You are telling me whether I believe. He said, no, it's like we have all been saying, it's a propaganda, government is just doing it. And the worst one I heard, which I don't know whether anybody in this gathering has heard, said that doctors are even giving the diagnosis when it's not there so that they can have money. That they are using the doctors to get somebody who is not COVID positive to say it's positive. And even if somebody dies and it's not COVID that killed the person, the doctors will write COVID. I mean, as stupid as that. That was what the person was telling me. So, and I said, you see, this is our country, we are really in trouble. I said, do you know what you are saying? How can doctor write what did not kill the patient and say, and the relations everybody knew? He said, they just tell them, they are putting it for them so that they can get money. It's as bad as this. We are really in a mess concerning this compliance issue, because the stories, and they believe those people, say doctor is lying. Oh, can you imagine if a patient says doctor is lying about diagnosis? This is very, very sad to hear that, and nobody has any authentic or valid evidence of these things. All is hearsay. If you tell this person, okay, show me the doctor, you say, they said it's one person that said, you know, and it's burning like wildfire. Rumor. So I think, like we have said, we have to have a behavioral change. Yes. The government has to enforce it. Yes. And we must also be ready to, like we have said, know where you get water, know where mask. I did something when my daughter got married early this year. The souvenir I packed, I put sanitizer, I put face mask. That's the souvenir I gave people. I wish we can do more, because even offices don't have sanitizer. Government offices, federal government offices, I don't want to be mentioning this because I am in a federal government establishment. No face mask for people, no sanitizer. But if such a thing can be given as part of our, is it a fringe benefits or what do we call that? Then that would have also helped some people. I know people who are working should be able to afford to buy it for their own health. I'm just saying some things that we have to do to make this thing really come back to life and let people know that we really need to be put our hands on deck and be in business.
Thank you very much. Thank you very much. I saw Professor Shaibu signing in. He has overcome the COVID network issue. And Professor Shaibu, can you unmute and quickly speak to us for 2 minutes? 2 minutes, all right. It's a challenges, but nevertheless, I'm happy I'm here with you now, and thank you all. Why do people not obey the protocols? I think it's something that we need to get to the root of, but it appears to me very easy. I think it's a disconnect between people's experience and the message being sent out. What we usually send out is the number of diseases that are available and the fatalities that are available, and therefore we are essentially putting out a case fertility rate. Case fertility rate is scientific terms that only scientists will understand.
what people experience is mortality rate, i.e., how many people are dying by population. With COVID-19 in Nigeria, it is very low. Unless you explain this up forward, there will be a disconnect between the message you are sending out and what people experience. COVID-19 is there, it's killing people, but nobody knows anybody in his community has been killed by COVID-19. And somebody may know one person, big man that was mentioned in the newspaper, or one person in one area. Now, that disconnect tends to make it very difficult for people to follow the instruction. Especially, it means that they don't feel any immediate threat, no matter what you say. And so this has been one of the main reasons I've been able to find out, because you see doctors in teaching hospitals that are so knowledgeable, they don't put on masks. They don't even worry. We had an NMA meeting in Sokoto, and I think it was around 5 or 4 of all the doctors that were putting on masks. And these are the people that are supposed to communicate the message. So what do you expect the population to do? Secondly, we are very religious people that have the God factor very high in our affair in Nigeria. The God factor means everything is taken care of by God, even your finance. If you allow us, we prefer to stay at home and open the box and see money there, because God takes care of things for Nigerians. God loves Nigeria. So, and therefore, the people that can communicate with the God factor are the malams, the pastors, and if those ones are not the one leading the call, then the Nigerians will now be faced between making a choice, the science and what the religious people are saying. Unfortunately, the message the religious people are passing is contrary. And I'm telling you, many professors would prefer to believe the religious people rather than what they read in science. This is because when the chips are down, as I've seen in many, many areas, many scientists, many people with a lot of knowledge when it comes to critical issues concerning health, prayers and prayer warriors make a lot of input, irrespective of the drugs they are taking. So if the society has something like this, then you're going to have a lot of challenge when you pass a message that is disconnected from the experience of the people. So going forward, I think we need to make the message clear. It is a dangerous thing. This is a potential risk. And it makes sense to take care of it before it becomes a dangerous threat that you cannot reverse easily. And go through the religious people in Nigeria so that they can pass the message. If they see people with goggles and coats passing the message all the time, you're going to have a lot of challenges for people to believe you and follow you. And your most difficult opponents will be people who should be your supporters, i.e. the doctors and the scientists, are going to be follow the population rather than follow the science, unfortunately. Thank you. Try to keep it short. I'm going to say a lot more.
Thank you very much. Professor Jegede, I yield back to you.
Yeah.
So.
Thank you very much for the presentations. I think we have made a lot of contributions to the prevention activities of the pandemic today, even though the number of participants on this platform is limited, but we do something that will make it to get to the wider community, which I will discuss with Professor Tijani after this meeting. So I want to thank everyone once again for coming. This is just one of the series of webinars that we put in place that we have on this platform. So we'll continue to brainstorm and then come up with ideas of more relevant and timely issues to discuss. So once again, I want to thank Professor Asusu, Professor Okoye, Professor Abu, Dr. Amino, Professor Okoye, Bono, and Professor Jegede myself for and Professor Aneto for that critical contribution. So we We'll get in touch again with you for the next round of webinar. Thank you very much.
Thank you very much, Professor Jegede. We will record our webinar and we make the video available after Mrs. Ashonibare as gracious editing of it. We want to thank everyone, the partnership with NCRC and NCDC. We thank all the participants. It is not the number, but the presence that really matters. And we will circulate the video widely. Thank you very much.
Right, thank you, sir.
And out. Bye-bye.
Thank you.
Bye-bye, everybody.
Thank you.
Bye. Bye.